Welcome, curious listeners, to The Deep Dive. Today, we're plunging into a topic that's utterly fascinating, incredibly complex, and yet something most of us completely take for granted: the incredible journey of wound healing.
hmm
Think about it: a simple paper cut, a scraped knee, maybe a surgical incision. Our bodies heal them, often without us giving it a second thought, really. But what exactly is happening behind the scenes? What's the biological masterpiece unfolding within us?
It truly is remarkable, isn't it? We pulled together a stack of sources for this deep dive, a really comprehensive look at the history, the intricate biological phases, common obstacles, and the cutting-edge treatments in wound care.
Right.
Our mission today is to sort of transform this rich medical information into accessible, maybe surprising, and truly well-informed insights for you. You'll discover why even a tiny wound is really a marvel of biological engineering, and what happens when that process, which we rely on so heavily, goes awry.
Exactly. We're going to uncover centuries of human understanding, from ancient remedies right up to modern biotechnology. Okay, let's unpack this and start at the very beginning of humanity's quest to fix itself. Aye, the ancient roots of healing, a timeless quest. It's wild to think about, but people have been trying to heal wounds for thousands of years. Imagine needing a magic spell just to help a cut. I mean, I still feel like I need one when I get a really bad paper cut sometimes.
Yeah.
What we learned is that the Sumerians, way back in 2000 BC, had some of the earliest documented approaches. They combined spiritual incantations with practical application of poultices. But beyond the magic, what was the practical wisdom they stumbled upon?
Well, what's truly fascinating here is how these ancient principles, creating an antibacterial environment using absorbent materials and forming a protective barrier, they remain foundational in modern wound management, still today. The Egyptians, around 1650 BC, were, well, incredibly advanced for their time. They were actually the first to even distinguish between infected and non-infected wounds, which was a crucial leap in understanding.
That's a huge step. We're talking about the Edwin Smith surgical papyrus from, 1650 DC, which describes at least 48 different types of wounds. And the Ebers papyrus from 1550 BC detailed their healing concoctions. They famously used honey, which we now know has significant antibacterial properties and remarkably is still used today in some contexts. Isn't that something?
It really is.
They also used lint for absorbency and grease to create a barrier. It's wild to think these basic, kind of intuitive ideas persisted through millennia.
Indeed. It shows a really astute observational capacity that predates modern science. Then we move to the Greeks, specifically Galen of Pergamum, who lived from 120 to 201 AD. He served as the doctor to Roman gladiators, so he dealt with an enormous number of wounds you can imagine.
Wow.
Galen was significant for his classification of wounds into acute and chronic, but maybe even more so for his radical emphasis on maintaining a moist environment for healing.
Wow. That's truly remarkable to think that concept, which sounds so modern, was understood so far back. What took us so long to prove it scientifically?
Well, our sources highlight that it took almost 19 centuries for this concept to be scientifically validated. 19 centuries.
No way.
And when it finally was, studies showed a 50% increase in epithelialization rate. That's the skin closing over the wound in moist conditions compared to dry.
50%.
Yeah. It underscores how some fundamental truths are observed long, long before the scientific means exist to fully explain them.
From the ancients, we jump forward to what truly revolutionized wound care.
Well,
The dawn of antiseptics. This was a true paradigm shift, wouldn't you say?
oh, absolutely. The understanding of how disease spreads underwent a complete transformation. Ignaz Philipp Semmelweis, a Hungarian obstetrician in the mid-1800s, made this critical observation. He noticed that the incidence of puerperal fever, a devastating infection in new mothers, was significantly lower if medical students washed their hands with soap and hypochlorite after cadaver dissection and before attending childbirth. He didn't fully understand why exactly, but he saw the dramatic effect.
He intuited the connection.
Yeah.
Then came Louis Pasteur, whose work in the mid to late 1800s was just instrumental. He famously dispelled the theory of spontaneous generation, proving that germs weren't just, popping into existence, they were introduced from the environment. This was the scientific backing needed, really.
And that's where Joseph Lister comes in, making what is arguably one of the most significant contributions to wound healing. In 1865, on a visit to Glasgow, Lister observed that parts of the city's sewer system were clearer than others.
Okay.
He discovered this was due to waste containing carbolic acid, or phenol.
So he took that observation and applied it directly to medicine. He started soaking his surgical instruments in phenol and even spraying the operating rooms with it. The research shows that this dramatic intervention reduced post-operative mortality rates from a horrifying 50% down to 15%.
15%.
That's an astonishing improvement. Imagine going into surgery knowing there's an 85% chance you'll make it out compared to 50%. Just incredible.
A profound impact indeed, saving countless lives. Lister's work was widely influential. In 1876, Robert Wood Johnson, after attending one of Lister's lectures, was inspired to embark on a decade of research.
10 years.
10 years. This eventually led to the production of antiseptic dressings, basically cotton gauze impregnated with iodoform. This was the commercialization and widespread application of Lister's insights, making antiseptic practices accessible.
And from there, it just exploded, didn't it? The 1960s and 70s saw the development of polymeric dressings. We're talking about custom-made materials with specific properties like permeability to gases, varying absorbency, and different physical forms.
Exactly.
This ability to customize based on the wound's needs led to an exponential growth in wound care materials.
Indeed. If we connect this to the bigger picture, it's a journey from, rudimentary observations and maybe spiritual beliefs to a deeply scientific, tailored approach for each patient.
Mm-hmm.
Now, modern practices involve highly sophisticated manipulations of inflammatory cytokines, growth factors, and bioengineered tissues. We're moving towards precision medicine in wound healing, where treatment strategies are customized based on the individual host, the specific underlying mechanisms, and even the organisms present in the wound bed. It's really a testament to how far we've come.
Yeah.
2, the intricate dance of healing phases, a biological masterpiece.
Now let's zoom in from the historical overview to the incredible biological marvel that is wound healing itself. It's truly a complex process, isn't it? Involving an intricate dance of overlapping phases that kicks off the moment an injury occurs. It's not a simple switch, but a coordinated cascade.
That's right. Normal wound healing is generally divided into 3 main overlapping phases. First, haemostasis, which is stopping the bleeding and inflammation. Second, proliferation, which is all about building new tissue. And finally, maturation and remodeling, where the new tissue gets stronger.
Okay.
Epithelialization, the skin closing over the wound, occurs throughout as a kind of final sealing step. The key is that a successful reestablishment of tissue integrity absolutely requires a progressive movement through all these steps. Any interference, and you're looking at delayed or non-healing wounds.
So let's break down that first immediate response, hemostasis and inflammation. What happens the second you get a cut?
Well, the very act of wounding disrupts your tissue, exposing the underlying extracellular matrix to these tiny blood cells called platelets. This immediately triggers platelet aggregation. They clump together and activation of the coagulation cascade, forming a clot.
Right, stops the bleeding.
Exactly. But think of these tiny platelets not just as clot makers, but as the body's rapid response architects. They immediately flood the zone with signals that tell everything else what to do next. Beyond just stopping the bleeding, that initial fibrin clot actually acts as a crucial scaffold, providing a pathway for inflammatory cells like neutrophils and monocytes to migrate into the wound.
So once the bleeding is stemmed, the real work begins, and the first wave of cleanup crew arrives. Specialized white blood cells we call neutrophils. Think of them as the body's microscopic janitors and first line of defense, maybe?
Precisely. These first responder cells rush to the wound within a day or two, drawn by a complex array of chemical signals. Their main role is phagocytosis, literally eating bacteria and tissue debris.
Okay.
But they're not just cleaners. They're also a major source of early signaling molecules, called cytokines, that influence subsequent new blood vessel formation and collagen synthesis. They also release enzymes like collagenases, which help break down old matrix in the early stages, clearing the way for new tissue.
This raises an important question, though. If these neutrophils are so vital for fighting infection and initial cleanup, why are there factors implicated in delaying wound closure sometimes?
That's a crucial point.
Yeah.
While essential for infection control, their prolonged presence or overactivity, particularly through the release of too many enzymes, can actually hinder the delicate process of new skin cells growing over the wound, delaying the final closure. It's a real fine balance between beneficial action and potential harm.
Right. Okay. So after these first wave of janitors, who's next in line?
Macrophages. These are derived from circulating blood cells called monocytes and are absolutely essential for successful healing. They appear in significant numbers by, say, 2 to 4 days post-injury and remain until healing is complete.
And they have a dual role.
They do. Like neutrophils, they continue to debride the wound by eating debris and contribute to fighting microbes by producing things like oxygen radicals.
But they do more than just cleanup, right? They're also orchestrators of the next phases.
Exactly. Their central function is activating and recruiting other cells. They do this through releasing various mediators like growth factors. These mediators regulate how cells grow and multiply, how new matrix is built, and critically, angiogenesis, the formation of new blood vessels. They are deeply involved in regulating both new blood vessel growth and the creation and reshaping of the new tissue matrix.
And what about T lymphocytes? Our sources mention them peaking at about 1 week.
T lymphocytes are less numerous, yeah, but they play a subtle yet important role in bridging the inflammatory phase to the rebuilding phase. While their exact full role isn't fully defined, research suggests they actively modulate the wound environment. For instance, reducing the number of these T lymphocytes in a wound can actually decrease its strength and collagen content.
Interesting.
Conversely, certain subsets can enhance healing. They also influence the cells that produce collagen, showing the complex interplay beyond just, soluble factors.
So once the initial cleanup and inflammation are managed, we move into phase 2, proliferation, the rebuilding stage. What's happening here typically from days 4 to 12?
This is where tissue continuity begins to be reestablished. Two key cell populations arrive: fibroblasts and endothelial cells. Fibroblasts are like the architects of the new tissue, drawn to the site by powerful chemical signals.
Okay.
Once there, these fibroblasts multiply and become activated, primarily by growth factors released by those earlier macrophages we mentioned.
So fibroblasts are literally building the new tissue.
Precisely. Fibroblasts from healing wounds synthesize more collagen than normal fibroblasts, and they actively engage in matrix contraction, pulling the wound edges together. The rich chemical environment in a wound significantly influences this change in their behavior. And interestingly, lactate, a byproduct of metabolism that accumulates in the wound, acts as a potent regulator of collagen synthesis. Simultaneously, endothelial cells proliferate extensively to form new capillaries. This is angiogenesis, which is absolutely essential for successful wound healing, providing the necessary blood supply to the new tissue.
Right. Need that blood supply.
Yeah, they migrate from existing blood vessels near the wound, and their migration, replication, and new capillary formation are influenced by growth factors. Macrophages, as we mentioned, are a major source of a key growth factor called VEGF in the healing wound.
That leads us to phase 3, matrix synthesis, which is all about building that structural scaffold. And collagen is the star of the show here, right?
It absolutely is. Collagen is the most abundant protein in the body, and its deposition, maturation, and subsequent remodeling are critical for the functional integrity of the wound. While there are many types, type I collagen is the major component in normal skin, but type 3 becomes more prominent and crucial during the initial repair process itself.
So how does the body build this collagen? What's the biochemistry involved? Is it complex? It's quite an intricate process, yeah. Imagine tiny protein chains that need to be folded and assembled correctly. This process requires several specific steps, and critically, vitamin C is essential for one of these steps, a process called hydroxylation, which gives collagen its stability.
Ah, vitamin C.
Yep. Without adequate vitamin C, collagen synthesis is severely impaired.
Fascinating. So vitamin C isn't just for preventing scurvy, it's absolutely fundamental to literally rebuilding your body after an injury.
Exactly. After these initial steps, the collagen strands undergo further processing and cross-linking outside the cell to form the final, robust collagen fibers. This entire process is highly dependent on systemic factors like adequate oxygen, sufficient nutrients, cofactors like vitamins and trace metals, and a healthy local wound environment free from infection.
And what about proteoglycans? They sound like part of the ground substance. They are. Think of them as the filler or ground substance in granulation tissue, the new bumpy tissue that forms in a wound. They combine with proteins to form proteoglycans. In wounds, two specific types, dermatan and chondroitin sulfate, are major components, synthesized by fibroblasts and peaking in the first 3 weeks.
Okay.
Their interaction with collagen is critical for assembling collagen subunits into organized fibers. As the scar matures, proteoglycans gradually diminish.
Then we move into the final refining phase, maturation and remodeling. This is where the scar really takes shape, starting even during the fibroblastic stage, you said.
That's right. This phase is about reorganizing the newly synthesized collagen. Collagen is continuously broken down by specific enzymes called matrix metalloproteinases, or MMPs. Think of them as the body's tiny biological scissors, constantly trimming and reshaping the collagen scaffold.
Right.
The net collagen content in the wound is a balance between this breakdown and new collagen synthesis. The goal is to reestablish an extracellular matrix composed of a relatively acellular, collagen-rich scar.
And wound strength is key here, right? How strong does it get?
It is key. Wound strength and mechanical integrity depend on both the quantity and the quality of the newly deposited collagen. The matrix is deposited in a specific pattern, with initial components like fibronectin and type 3 collagen appearing early, followed by the ground substance components, and finally the stronger type I collagen.
Okay.
While the overall collagen content might plateau after several weeks, the tensile strength continues to increase for several more months. However, and this is important, the mechanical strength of the scar never achieves that of the uninjured tissue.
So a healed scar is never quite as strong as the original skin. That's a critical detail. And there's constant turnover even after it's formed.
Yes, there's constant collagen turnover, with collagenase activity strictly controlled by signaling molecules and growth factors. For example, a growth factor called TGF-beta has this kind of dual role. It increases new collagen synthesis while also decreasing collagen breakdown by stimulating the body's natural inhibitors of those collagen-cutting enzymes. This delicate balance of collagen deposition and degradation ultimately determines the final wound strength and integrity.
Then the final seal. Epithelialization, the skin closing up.
This is the critical last step to reestablish tissue integrity, primarily through the proliferation and migration of epithelial cells adjacent to the wound. It begins within a day of injury, as the skin at the wound edge thickens.
Okay.
Cells at the bottom layer of the skin, called basal cells, lose their attachment, enlarge, and migrate across the provisional matrix. They multiply rapidly, and these new cells migrate in a leapfrog fashion until the defect is covered.
Leapfrog fashion.
Yeah, that's how it's described. Once bridged, the migrating cells regain their normal shape, increase mitotic activity, reestablish layering, and finally form a protective outer layer.
So a simple cut is covered in less than 48 hours, but larger wounds take much longer. And what stimulates this final sealing process?
It's driven by a complex interplay of signals, a kind of go-ahead from the local environment, and specific growth factors like EGF, PGF-beta, and others produced by immune cells. For superficial injuries, like a skin graft donor site or maybe a superficial burn, healing is primarily by re-epithelialization with minimal or no scarring, because the deeper layers of the skin are still intact.
You mentioned growth factors several times. They sound like the orchestra conductors of this entire process.
They truly are. Growth factors and cytokines are powerful signaling proteins that stimulate cells to migrate, multiply, and perform specific functions. They're incredibly potent, producing significant effects even in tiny, tiny concentrations.
Really?
Yeah, they can act locally on the cells that produce them, on neighboring cells, or even travel through the bloodstream to distant sites. The timing of their release and the presence of the correct cell surface receptors are just as important as their concentration. They have diverse actions, attracting one cell type while stimulating the replication of another. It shows the exquisite specificity of the body's internal communication system.
And finally, there's wound contraction, which is a bit of a mystery, right? It starts before the main players arrive.
Yes, that's a fascinating bit. All wounds undergo some degree of contraction, especially open wounds, healing by secondary intention, where the wound area is visibly reduced. The myofibroblast is considered the major cell responsible for this.
Okay.
It's a specialized fibroblast that develops contractile capabilities, almost like a miniature muscle cell. However, these specific cells aren't detectable until about day 6.
Okay, let's unpack this. The body has a pre-game show for healing even before the star players arrive. You're saying contraction starts immediately before myofibroblasts are even detectable. That's wild.
It is a puzzling point that suggests fibroblasts play an earlier role.
Yeah.
Studies show fibroblasts in a collagen framework can actively move and contract it without expressing those specific contractile elements we see later. It's thought that the initial movement and reorganization of the internal scaffolding within these early fibroblasts are responsible for that immediate early contraction. Then, the myofibroblasts take over the sustained, more powerful contraction later on. It's a truly dynamic, multicellular effort from start to finish. 3. When healing goes awry. Genetic factors and specific tissue challenges.
We've covered the amazing normal healing process, but what happens when things go wrong? Our bodies are incredible, but they're not always perfect. Let's talk about heritable diseases of connective tissue, which can present unique surgical challenges.
Right. These are genetically determined primary disorders affecting collagen, elastin, or mucopolysaccharides, the very building blocks of our tissues.
Hmm.
They can dramatically alter the healing landscape because they affect the fundamental structural components.
Let's start with Ehlers-Danlos syndrome, or EDS. What is it, and how does it impact healing?
EDS is actually a group of 10 disorders, primarily characterized by a defect in collagen formation. This leads to a wide range of findings: thin, fragile skin with prominent veins, easy bruising, and crucially, poor wound healing.
Poor wound healing.
Yeah. Patients also experience atrophic scars, recurrent hernias, and overly flexible joints. There's also gastrointestinal and vascular fragility, meaning aneurysms or ruptures can occur, which is obviously very serious.
So surgically, it must be incredibly difficult to work with.
It is. Surgeons must exercise extreme care to avoid tearing skin or the underlying connective tissue, the fascia. Wounds also need to be closed in 2 layers with sutures under tension, and stitches have to remain in place twice as long as usual, often reinforced with external tape due to the inherent tissue weakness.
Wow. And Marfan syndrome, is that similar in terms of healing?
Marfan syndrome involves tall stature, lax ligaments, and a risk of aortic aneurysms stemming from a genetic defect in a crucial structural protein called fibrillin. What's fascinating here, and provides a comparative aha moment, is that while their skin might be overly flexible, patients with Marfan syndrome show no delay in wound healing.
Really? No delay.
No delay. This tells us that not all connective tissue defects impact healing in the same way, highlighting the specificity of these genetic issues.
What about osteogenesis imperfecta, famously known as brittle bone disease?
OI is caused by a mutation in type I collagen, the main collagen in bones. Patients have extremely fragile bones, dermal thinning, and increased bruising. Interestingly, while their bones are incredibly fragile, their skin is not overly flexible and their scarring is normal.
Normal scarring.
Normal scarring. Surgical difficulties mainly arise from the risk of bone fracture under minimal stress.
And epidermolysis bullosa, or EB, sounds like a nightmare for skin adhesion.
It is. EB involves impaired tissue adhesion within the skin layers, leading to blistering with minimal trauma. Genetic defects in proteins responsible for skin adhesion result in this severe blistering. Managing non-healing wounds in these patients is extremely challenging due to nutritional compromise from oral erosions and esophageal obstruction.
Oh, wow.
Yeah. Incisions must be meticulously placed to avoid further trauma, and non-adhesive, bulky dressings are essential to protect the fragile skin.
Lastly, acrodermatitis enteropathica. This one is about zinc, right?
Yes. It's a rare autosomal recessive childhood disease where the body can't absorb enough zinc. Zinc is a critical cofactor for over 150 enzymes, including those involved in cell replication.
150 enzymes.
Yeah. A deficiency impairs healing by inhibiting cell proliferation, leading to characteristic skin dermatitis. Crucially, oral zinc supplementation is curative. This underscores the profound impact of even single nutrient deficiencies on healing.
So beyond these systemic genetic conditions, do different tissues in the body heal differently, even with the same general mechanisms?
Oh, they do. While the fundamental phases of healing are similar across tissues, there are significant differences based on the specific tissue structure, its vascularity, and its primary function.
Let's take the gastrointestinal tract. That's a big one for surgeons, I imagine.
Absolutely vital for absorption, barrier function, and motility. Surgical repairs, usually with sutures or staples, face challenges like dehiscence, where the wound opens up leaks, or fistulas if healing fails, which can be life-threatening.
Right.
Conversely, excessive healing can lead to strictures or narrowing, stenosis. The submucosal layer is key here, providing the greatest tensile strength and suture-holding capacity. The serosa, the outer lining, is also crucial for a quick, watertight seal, which is why segments outside the peritoneum like the esophagus and rectum have higher failure rates. They lack that serosal layer.
So GI tract healing is different from skin, even though the same phases occur.
Yes, there are significant differences. For one, mesothelial and mucosal healing in the GI tract can occur without scarring, unlike adult skin. Also, there's a significant early decrease in strength due to marked breakdown of collagen, sometimes exacerbated by bacteria like Pseudomonas.
Ah.
The integrity of the anastomosis, that's where 2 ends are joined, is a dynamic balance between collagen breakdown and new synthesis. Technical considerations like ensuring a tension-free connection and adequate blood supply are paramount. Overzealous fluid administration, which can cause tissue edema, can also compromise healing by affecting small vessel blood flow right at the connection point.
What about bone? That seems like a very different kind of healing process altogether.
Bone healing also involves an initial blood clot formation, then the removal of dead tissue, and the formation of new blood vessels. This is followed by a soft callus stage, where fibrocartilaginous tissue forms a bridge, and then a hard callus stage, where this bridge mineralizes into bone. Finally, there's a remodeling phase that reabsorbs excess bone and restores the marrow cavity. Growth factors like bone morphogenic proteins, BMPs, are crucial here, stimulating the cells that build cartilage and bone.
And cartilage, which is a vascular, must be a challenge. No blood supply.
Indeed. Cartilage relies on diffusion for nutrients, with the surrounding membrane, the perichondrium, aiding nutrition. Its healing depends on the depth of injury. Superficial injuries show slow, incomplete regeneration by cartilage cells, chondrocytes, with no inflammation. Deep injuries, however, involve the underlying bone, allowing blood vessels to reach the area, initiating inflammation, and eventually leading to the formation of new cartilage, which can restore structural and functional integrity.
Tendons and ligaments, they're all about mechanical strength, aren't they?
They are. Tendons and ligaments are dense bundles of collagen fibers. Their healing is similar to other areas through hematoma formation, organization, and reparative tissue. However, their mechanical integrity may never equal that of undamaged tissue.
No.
That's what the sources suggest. Blood supply plays a role. Tendons with poor blood supply tend to heal with more scar tissue. The specialized tendon cells, penocytes, do have high regenerative potential, though.
And nerves. That sounds incredibly complex, repairing nerves.
Nerve injuries involve three crucial steps: survival of the nerve cell bodies, regeneration of the nerve fiber, the axon, across the transected nerve, and the successful migration and connection of these fibers to their targets.
Right.
After injury, the part of the nerve fiber detached from the cell body degenerates, that's Wallerian degeneration, and specialized cells called Schwann cells are crucial for clearing debris and guiding remyelination. Various growth factors and cell adhesion molecules play complex interacting roles in guiding this nerve regeneration.
Here's where it gets really interesting. Imagine a future where adult scars are a thing of the past. What we discovered is that fetal wound healing is described as the holy grail of regeneration because it's characterized by a lack of scar formation.
It's truly a profound area of research. This scarless healing in fetuses resembles true tissue regeneration, offering immense promise for potentially manipulating unwanted scarring in adults. While early fetal healing is entirely scarless, there's a transition wound phase in the early third trimester, where scarless healing still occurs, but without skin appendage regeneration, like hair follicles.
Okay.
Eventually, a more adult-like scarring pattern emerges, though healing generally remains faster than in adults.
So what makes fetal wounds heal so perfectly without a scar? Is it just the amniotic fluid, that sterile bath?
Well, the wound environment plays a part. The fetus is bathed in sterile, temperature-stable amniotic fluid. However, experiments have shown scarless healing can occur outside this environment, and conversely, scars can form in utero, so it's not the sole reason.
Oh, okay.
The key differences seem multifaceted. Firstly, inflammation is significantly reduced in fetal wounds due to an immature immune system, with lower numbers of early inflammatory cells like neutrophils and macrophages. The extent of inflammation directly correlates with scar formation.
So less inflammation, less scar. That's a huge insight.
Precisely. And crucially, fetal wounds are notable for the absence of a specific form of TGF-beta, a growth factor heavily implicated in adult scarring.
Right, TGF-beta.
Yeah. Blocking specific types of TGF-beta, like TGF-beta 1 and 2, in adult wounds significantly reduces scar formation. Conversely, applying a specific type, TGF-beta 3, to a fetal wound can actually induce scarring. This highlights that the balance between the concentration and/or activity of different TGF-beta forms is vital for regulating scar production.
That's fascinating. So if we could control TGF-beta in adults, we might reduce scarring. What else is different in the fetal wound matrix? The actual stuff being built.
Fetal wounds are characterized by excessive and extended hyaluronic acid production. Hyaluronic acid is a large sugar molecule, a glycosaminoglycan, that's part of the ground substance.
Okay.
While adult wounds also produce hyaluronic acid, its synthesis is sustained only in the fetal wound. This hyaluronic acid may aid in the orderly organization of collagen. Fetal fibroblasts also produce more collagen than adult fibroblasts, and the collagen pattern in fetal wounds is reticular, kind of net-like, resembling surrounding tissue, unlike the large perpendicular bundle seen in adult scars. This has even led to topical hyaluronic acid use in some modern treatments, attempting to mimic those fetal conditions. 4. Obstacles to optimal healing, systemic and local factors.
So that's the ideal biological masterpiece. But what happens when things don't go as planned? When healing is delayed or completely impaired, what we learned is that wounds are classified into two main categories.
Right. We have acute wounds, which heal predictably within a normal time frame, and chronic wounds, which fail to heal after typically 4 weeks or sometimes up to 3 months.
Got it.
Surgical wounds themselves can heal in a few ways. Primary intention is when a clean incised wound is closed directly with sutures. Straightforward. Secondary intention is when a wound, perhaps due to contamination or significant tissue loss, is left open to heal by granulation and contraction from the edges inward. Takes longer.
Okay.
And then there's tertiary intention, or delayed primary closure, where sutures might be placed. But the wound is left open for a few days to allow for drainage or observation before final closure.
And the spectrum of healing shows this clearly. Normal healing reaches maximal strength around 6 weeks, but even then, it only achieves, 75% to 80% of normal tissue strength? It never gets back to 100%.
Exactly. That's a key point. Delayed healing means an initially decreased strength, but if the underlying issues are corrected, it can eventually reach the same ultimate integrity. Impaired healing, however, is a failure to achieve normal strength at all, often seen in immunocompromised patients or those with severely damaged tissues. Understanding these classifications is crucial for predicting and managing outcomes.
Now, let's dive into the systemic and local factors that can really throw a wrench into this intricate healing machine. What about advanced age? Is it true that older people heal slower?
It's a common clinical belief, and indeed, studies show a correlation between older age and poorer wound outcomes like wound opening, dehiscence, or incisional hernia. However, much of this can likely be attributed to underlying illnesses, metabolic diseases like diabetes, cancer, or the medications often taken by the elderly, rather than age itself.
Ah, okay, so it's not just the number.
Probably not just the number. In healthy elderly individuals, while there might be a delay in skin closure, epithelialization, and a decrease in non-collagenous protein accumulation, collagen synthesis itself doesn't appear significantly impaired. Age generally seems to cause a delay, not necessarily complete non-healing.
Hypoxia, anemia, hypoperfusion, these sound like major problems for healing. Lack of oxygen, low blood count, poor blood flow.
They have a profoundly deleterious effect. Low oxygen tension significantly impairs the growth of new cells, fibroplasia, and collagen synthesis, as oxygen is a crucial cofactor for collagen's formation, remember.
Right, needed for those steps.
Yeah. What we learned is that increasing the fraction of inspired oxygen, the VO2, during and after surgery has actually been shown to enhance collagen deposition and reduce infection rates.
So getting enough oxygen to the wound is critical? Seems obvious, but how do we ensure that?
Absolutely. Factors like low blood volume, heart failure, local narrowing of blood vessels, vasoconstriction, or excessive tension on tissues can all lead to local hypoperfusion, meaning not enough blood flow. The tiny capillaries just beneath the skin are exquisitely sensitive to fluid status, temperature, and sympathetic tone, like from postoperative pain or stress.
Wow.
Correcting these factors, maintaining adequate hydration, warmth, and pain control can remarkably influence wound outcome, especially reducing infection. While mild anemia isn't a huge factor, profound anemia can certainly interfere.
What about medications like steroids and chemotherapeutic drugs? How badly do they affect things?
Large doses or chronic use of glucocorticoids, like prednisone, significantly reduce collagen synthesis and wound strength. They do this by inhibiting the inflammatory phase, affecting new blood vessel formation, cell migration, and fibroblast proliferation. Generally, the stronger the steroid's anti-inflammatory effect, the greater the inhibition on healing.
Okay.
If possible, their use should be delayed until after the first 3 to 4 days post-injury, when their impact is less severe.
So timing is important. Can anything reverse this if someone has to be on steroids?
Yes, interestingly, topical vitamin A can actually reverse steroid-delayed healing by stimulating skin cell growth and collagen synthesis.
Vitamin A, really?
Yeah. As for chemotherapeutic antimetabolite drugs, they adversely affect healing by inhibiting cell proliferation and DNA protein synthesis. Their effects are worse if given preoperatively, so delaying their use for about 2 weeks after injury is often recommended if possible. Extravasation, meaning leakage of these drugs outside the vein, also causes significant tissue necrosis and protracted healing, which is a major problem.
Metabolic disorders like diabetes must be a huge challenge for wound healing. We hear about diabetic foot ulcers all the time.
Diabetes mellitus is a major contributor to increased wound infection and failure rates. Uncontrolled diabetes reduces inflammation, new blood vessel formation, and collagen synthesis. This is compounded by large and small blood vessel disease, macro and microvascular disease, impaired immune cell function, specifically granulocytes, and potentially insufficient growth factor levels. Even in clean, well-perfused wounds, uncontrolled type 1 diabetes can decrease collagen accumulation.
So managing blood sugar is paramount.
Preoperative blood sugar control is vital, absolutely. Other measures include ensuring good oxygenation, judicious use of antibiotics, and sometimes revascularization for chronic ulcers. Kidney failure, or uremia, is also associated with disordered healing and impaired infection defense, often complicated by malnutrition. Dialysis can help, but it's complex.
And obesity, a growing public health problem, how does that factor in? Just mechanically or more?
It's more than just mechanical. Obesity, even uncomplicated by other conditions, has direct deleterious effects on wound healing. The fat around organs called visceral adiposity is metabolically and immunologically active, generating pro-inflammatory signals that affect healing cells. Obese patients have significantly higher rates of perioperative complications. Wound opening, surgical site infections, incisional hernias, fluid collections called seromas, hematomas, and fat necrosis. Increased subcutaneous fat, in particular, is associated with a tenfold increased risk of complications.
This raises an important question. Why does obesity cause so many wound complications? And what specifically is happening at the cellular level? Is it just poor blood supply in the fat?
It's likely more complex than just blood supply. While the exact mechanism isn't fully delineated, studies show that wounds in obese individuals are mechanically weaker with less new collagen. It seems that fat cells, adipocytes, can infiltrate the new tissue, and while they can evolve into cells that look like fibroblasts, their regulatory mechanisms differ from normal fibroblasts. This suggests a fundamental cellular difference in how they contribute or fail to contribute to wound repair. This metabolic and cellular dysregulation within the fat tissue itself seems to interfere with optimal healing processes.
Nutrition has been historically linked to healing since Hippocrates, right? What are the key nutrients we should be aware of?
Absolutely. It's fundamental. Protein and energy deficiencies profoundly impair collagen deposition and wound strength, and even brief nutritional interventions can improve outcomes. Several nutrients really stand out. Arginine is considered the most active amino acid for enhancing new tissue formation, fibroplasia, in wounds. Supplementation has been shown to increase collagen deposition even in healthy individuals.
Interesting. And vitamin C, again, essential for collagen.
Yes, vitamin C is absolutely essential for collagen synthesis, specifically for crucial steps in its formation, the hydroxylation steps. Deficiency, or scurvy, directly impairs healing and is linked to increased infection rates due to impaired immune cell function, specifically neutrophil function.
And vitamin A, you mentioned it regarding steroids.
Right. Vitamin A deficiency impairs healing, and supplementation even in non-deficient patients can benefit. And as we said, it can notably reverse corticosteroid-impaired healing by stimulating skin cell growth and collagen synthesis. It also boosts the activity of macrophages, those important orchestrator cells.
And zinc, you mentioned it earlier with acrodermatitis and neuropathica, so it's generally important.
Zinc is critical, serving as a cofactor for over 150 enzymes essential for healing.
Wow.
Deficiency impairs fibroblast proliferation, collagen synthesis, and epithelialization. These defects are reversed by zinc supplementation, though studies haven't shown clear benefit in patients who are not already zinc deficient. So supplementation might only help if you're low.
Finally, infection's a major problem for any wound, obviously.
Infections are a huge medical problem, leading to surgical failures, increased hospital stays, and cosmetic issues. Antibiotic prophylaxis, meaning giving antibiotics before surgery, is effective when antibiotics are present at the time of incision, and repeat dosing is crucial for long procedures.
Right.
However, antibiotics are for obvious infection where there's a host response, not just contamination or colonization. Indiscriminate use leads to multi-drug resistance, which is a massive global issue.
So we need to differentiate between contamination, colonization, and infection. How do we tell?
Yes, it's important. Contamination is just bacteria present without multiplying. Colonization is multiplication without a host response, no redness, pus, etc. Infection is the host response to bacterial multiplication, characterized by signs like cellulitis, spreading redness, abnormal discharge, delayed healing, foul odor, or systemic signs like fever.
Okay.
Deep infections like necrotizing fasciitis are particularly dangerous, with high mortality. It's an invasive process causing widespread tissue death and skin necrosis, requiring aggressive management with high-dose antibiotics and, critically, thorough surgical debridement. Multiple trips to the OR are often needed.
What about conditions like chronic granulomatous disease? That sounds specific.
Chronic granulomatous disease, or CGD, is a genetic deficiency in an enzyme, NADPH-dependent oxidase, which impairs the intracellular killing of microorganisms by immune cells.
Ah.
This leads to recurrent infections, granuloma formation, and poor wound healing. For these patients, surgical considerations include late suture removal and prolonged drain placement due to that slow healing.
And hyperglycemia, high blood sugar seems to pop up repeatedly as a risk factor for infection.
It's a significant one. Tight, but not too tight. Glycemic control has been associated with significant reduction in postoperative infections. Too tight can cause problems too. Furthermore, what we learned from Thomas K. Hunt's work highlighted the exquisite sensitivity of the tiny blood vessels just under the skin, the subcutaneous capillary bed, to low blood volume, low body temperature, and stress.
Right, you mentioned that.
Yeah, all these cause blood vessel narrowing, impairing oxygen delivery, and increasing infection risk. Maintaining adequate hydration, euvolemia, core temperature, and plane control collectively reduces infection rates. It's about optimizing the whole patient. V, the challenge of chronic wounds. Understanding persistent problems.
So we've discussed how normal wounds heal and what factors can impede that, but let's specifically focus on chronic wounds. These are the ones that truly fail to progress through that orderly healing process, typically remaining unhealed after 4 weeks to 3 months. They're a significant clinical challenge, aren't they?
They really are. Skin ulcers are a major component of chronic wounds, often appearing in traumatized or vascularly compromised tissue. The common perpetuating factors include repeated trauma, poor blood flow or oxygenation, and excessive inflammation. But beyond those, a key issue seems to be cellular unresponsiveness.
Cellular unresponsiveness. What does that mean at a biological level? What's going wrong with the cells?
It means the cells in these chronic wounds fail to produce normal growth factors, or perhaps there's increased breakdown of those factors due to a highly destructive wound environment, an environment with an overproduction of enzymes, proteases that break down tissue.
Okay.
Also, fibroblasts from chronic wounds show decreased ability to multiply, possibly due to cellular aging, senescence, or reduced sensitivity to growth factors, maybe fewer receptors. Essentially, the cellular machinery for healing becomes sluggish or dysfunctional. It's stuck.
And any long-standing wound can be prone to something called Marjolin's ulcer, right? Malignant transformation, cancer developing in a scar or wound.
Yes, any chronic ulcer carries that risk. Clinically, you might differentiate it by overturned wound edges, where the skin looks like it's rolling in on itself. It's critical to perform a biopsy to rule out squamous cell and basal cell carcinomas, as these can arise in such long-standing wounds. You have to think about it.
Let's look at some specific types of chronic wounds, starting with ischemic arterial ulcers. These must be incredibly painful, lack of blood flow.
They are typically extremely painful due to the severe lack of blood supply. They're strongly associated with peripheral vascular disease, presenting with symptoms like leg pain with walking claudication or rest pain.
Right.
They typically appear on the most distal parts of the extremities, like between the toes or on the heel, and are often shallow with smooth margins, a pale base, and diminished or absent pulses. The crucial management step here is revascularization, meaning restoring blood flow surgically or with procedures. Without it, these wounds generally won't heal. Wound care alone isn't enough.
Then there are venous stasis ulcers. What's the difference here? It's about veins, not arteries.
Exactly. These are due to blood pooling in the veins, venous insufficiency, and increased venous pressure. The exact cause is debated, but involves altered tiny blood vessels, leakage of proteins like fibrinogen, forming fibrin cuffs that might impede oxygen exchange, or abnormal immune cell adherence trapping growth factors.
Okay.
Clinically, you see brownish pigmentation, lipodermatosclerosis, which is hardening of the skin around the ankle, the gaiter area. The ulcer itself may have irregular margins and fail to heal over with new skin, despite good granulation tissue. They commonly occur above the inner ankle bone, the medial malleolus.
And treatment for venous ulcers, is it just dressings?
The cornerstone is compression therapy using rigid bandages, specialized multi-layered bandages, or compression stockings to support the veins and reduce swelling. That's key.
Right.
Wound care focuses on maintaining a moist environment. Modern approaches might include medications that affect blood vessels, growth factors, or skin substitutes. However, recurrence is very frequent, largely due to patient non-compliance with lifelong compression.
Diabetic wounds are unfortunately very common and a leading cause of amputations. You mentioned the factors earlier.
Yes, a significant problem, affecting 10–25% of diabetics at some point.
Yeah.
Major contributors are nerve damage neuropathy, both sensory, leading to unrecognized injury, and motor, leading to foot deformities like Charcot's foot. Ischemia, or poor blood flow from large and small vessel disease, also plays a major role.
Hmm.
These wounds have poor healing rates and high recurrence. Treatment is multi-pronged. Adequate blood sugar control, aggressive eradication of infection, often involving bone, osteomyelitis, wide surgical debridement, and, critically, offloading pressure from the ulcerated area with orthotics, special shoes, or casts. Topical growth factors like PDGF and engineered skin substitutes are also used, but prevention through meticulous foot care, regular checks, is paramount.
And finally, decubitus or pressure ulcers, bed sores. These sound like they're directly caused by prolonged pressure.
Precisely. They are localized tissue necrosis developing from compression between a bony prominence like the tailbone or heel and an external surface, accelerated by friction, shear forces, and moisture. Immobility, altered mental status, poor nutrition, and chronic conditions are major risk factors.
Okay.
You're staged from eye to eye, from simple redness that doesn't go away when pressure is relieved, to full-thickness tissue loss involving muscle or bone. Treatment requires a multidisciplinary team approach: wound care nurses, doctors, dietitians. It involves debridement of dead tissue, maintaining a moist wound environment, pressure relief, turning schedules, special mattresses, and addressing host issues like nutrition. Operative repair with tissue flaps is used for closure of severe ones, but recurrence rates are extremely high due to the vulnerable patient population and the difficulty in eliminating pressure completely. 6. Modern innovations in wound treatment. Pushing the boundaries of healing.
We've talked about the history, the biology, and the challenges. Now let's pivot to the cutting edge. Modern innovations in wound treatment. What are the fundamental principles of local wound care, and what new tools are out there? Are the basics still important?
Oh, absolutely. The basics of local care are still paramount. Meticulous examination of the wound, its depth, any dead tissue, foreign bodies is critical. You need to describe the wound thoroughly. Location, dimensions, type of drainage, characteristics of the wound base, and assess for infection, pain, and systemic factors that might be interfering.
Okay, let's unpack this. Even something as simple as cleaning a wound has very specific medically proven guidelines. It's not just splashing some antiseptic on it.
Absolutely not. Preparation involves meticulous anesthesia, exploration to identify any injured structures underneath, and cleansing. High-pressure irrigation with normal saline only is generally recommended for mechanical cleaning. You should avoid harsh chemicals like iodine, hydrogen peroxide, or other antibacterial preparations directly in the wound bed, as they can actually impair healing by injuring your own healing cells, like fibroblasts.
Right, kill the good guys too.
Exactly. Stopping bleeding, hemostasis, removing all non-viable tissue, debridement, and sometimes trimming irregular wound edges are also crucial first steps.
And then approximating the edges for optimal healing and cosmesis, getting it closed nicely.
Right. Selecting the smallest suture required is important to minimize inflammation. Non-absorbable or slowly absorbing monofilament sutures are often used for deep fascial layers for strength, while absorbable braided sutures might be used for subcutaneous tissues. For significant tissue loss, advanced surgical techniques like musculocutaneous flaps, free flaps, or split-thickness skin grafts might be needed to cover the defect.
And what about dermal glues? They sound convenient, especially for kids, maybe.
Dermal glues, like octyl cyanoacrylate, have shown good results for simple, linear wounds with clean skin edges under low tension. They're less brittle than older glues, have superior strength against tension compared to some traditional methods, can be suitable in some contaminated situations, and offer excellent cosmetic results with less trauma, especially in pediatric patients, compared to traditional sutures. No needles.
Right. When it comes to antibiotics, it's clear we need to be very targeted to avoid resistance. You stress that.
Precisely. Antibiotics should only be used when there's an obvious infection, meaning clear signs of a host response, like significant redness, swelling, pus, or fever. Indiscriminate use must be avoided to prevent the development of multidrug resistance. Treatment should be based on suspected organisms and the patient's immune status, tailoring single or broad-spectrum agents. Our sources note that topical antibiotics have questionable efficacy for deep infections. They might help superficial contamination, but won't penetrate deep enough.
Dressings have evolved so much from simple lint and grease. What's the main purpose now? What are we trying to achieve?
The main purpose of modern dressings is to provide the ideal moist environment for wound healing. This moist environment promotes collagen synthesis, epithelial migration, and limits desiccation, preventing the wound from drying out, which allows cells to move and work. However, completely sealing off a wound, Full occlusion is contraindicated in infected or highly exudative wounds, as it can inadvertently enhance bacterial growth by trapping moisture and heat.
And there are so many types now, it must be confusing.
Indeed, it can be. We have primary dressings placed directly on the wound and secondary dressings for added protection or absorption. Types include absorbent dressings for hairy drainage, non-adherent ones to prevent sticking, and occlusive, semi-occlusive dressings, which are waterproof, yet allow gases like oxygen and water vapor to pass through. There are also hydrophilic and hydrogel dressings that combine occlusion and absorbency for atraumatic removal, and alginates derived from algae, which are highly absorbent for wounds with a lot of fluid or tissue loss. There are even medicated dressings for drug delivery, like those containing zinc oxide or silver, which can have specific effects. Selection really depends on the amount and type of wound drainage and the goal of care.
And then mechanical devices like negative pressure wound therapy or NPWT, the wound vac, how do these work?
NPWT systems apply localized negative pressure, suction basically, to the wound surface and margins, usually through a foam dressing sealed with film. They augment dressings by effectively removing exudates excess fluid, controlling edema, and assisting wound closure by mechanically drawing the edges together and stimulating granulation tissue.
And they work well.
They've proven effective for various applications, including chronic open wounds like diabetic and pressure ulcers, acute and traumatic wounds, and even over surgical flaps and grafts to help them take. While more randomized trials are still being done to define optimal use, their clinical utility is widely recognized.
Moving beyond dressings, we get into more advanced bioengineered solutions, skin replacements and cellular and tissue-based products, or CTPs.
Right. Conventional skin grafts remain a cornerstone. Split-thickness grafts, containing epidermis and part of the dermis, require less blood supply and can cover large areas but may scar more. Full-thickness grafts, with the entire epidermis and dermis, offer better mechanical strength and cosmesis and resist contraction, but can only be used for smaller defects. Grafts can be autografts from the patient, ideal, allografts from other humans, temporary, risk rejection, or xenografts from other species, also temporary higher risks.
But the sources stress that none of these advanced solutions work without proper wound bed preparation. You can't just slap it on any wound.
That's absolutely critical. Adequate wound bed preparation, debridement of necrotic tissue, controlling swelling, ensuring good blood flow, and reducing bacteria is essential for the success of any skin replacement or bioengineered product. Without a healthy base, even the most advanced therapies will likely fail.
So CTPs are seen as a bridge between dressings and full skin grafts, maybe?
Or, in an alternative,
Kind of. They're complex and heterogeneous, and while they might accelerate the rate of healing, the sources emphasize they will not replace basic wound care. They presumably act by altering wound biology, providing cells or growth factors, or preparing the wound bed.
okay.
We categorize them as dermoinductive, providing cells or factors to induce growth, like Apigraph, a bilayered product with keratinocytes and fibroblasts, which showed significantly better healing for diabetic ulcers compared to just saline in studies. Or dermoconductive, providing a scaffolding for new dermis to grow on, like Integra, which is a bovine collagen matrix.
And stem cell-based therapy is gaining popularity here too. It is. Stem cells, often from sources like amniotic membranes, are being explored for enhanced healing, skin regeneration, and scar reduction as they produce various growth factors. However, a significant drawback, as you might expect, is their extremely high cost and often the recommendation for weekly applications.
Yeah, cost is always an issue.
CTPs offer advantages like being readily available off the shelf and avoiding painful harvests of skin, but disadvantages include limited survival of the cells within them, high cost, and often the need for multiple applications.
What about cultured epithelial autografts, or CEAs? Growing skin from a postage stamp-sized biopsy. That sounds futuristic.
CEAs involve expanding keratinocytes from a patient's own skin in a lab to create sheets to cover large areas like major burns. While they won't be rejected and look like normal skin initially, they are very fragile, susceptible to infection, and don't resist contraction well, leading to poor long-term cosmetic results because the deeper skin layer, the dermis, regenerates slowly underneath.
Ugh.
Fibroblast-based products are also used, growing fibroblasts on meshes to create living dermal tissue as a scaffold, which is generally less time-consuming and expensive than CEAs. The goal is to evolve to composite products that mimic normal anatomy, containing both epidermal and dermal components for better results.
Moving on to growth factor therapy directly. The idea is to flood a non-healing wound with the very factors it might be lacking. Seems logical.
That's the hypothesis, yeah. It seems like a potentially simplistic solution to jumpstart healing. While animal studies often show promise, human clinical translation has been somewhat limited. Autologous platelet-rich plasma, PRP, where a patient's own platelets are concentrated and used, has shown disappointing results overall in large reviews of studies for chronic wounds.
Really disappointing.
Generally, yes, for chronic wounds. Currently, PDGFBB is the only FDA-approved growth factor specifically for diabetic foot ulcers, where it has been shown to increase healing incidence and decrease healing time in some studies. More research is needed to understand the optimal concentration, the timing of release, and which cells are best to target with specific factors. It's complex.
So if purified growth factors aren't the magic bullet, what about gene or cell therapy? That sounds like the true frontier, delivering the instructions, not just the product.
It is. Gene therapy aims to deliver specific genes directly to the wound bed, often using viruses or other vectors, to get the wound cells themselves to express desired proteins like growth factors. Success in animal and human models has been reported but often described as modest and specific, showing benefits for particular aspects of healing but not a universal cure.
This raises an important question, though. How do we tell the body exactly when to start and, crucially, when to stop healing to avoid excess scarring or even tumor formation? Control is key, right?
That's the core challenge with gene therapy. Delivering extra genes requires precise on-off signals to avoid dysregulated or hypertrophic healing that's excessive, thick scarring. It's unlikely a single gene will be enough. The current thinking is towards delivering multiple genes synergistically and perhaps in timed sequences via activated cells, such as mesenchymal stem cells.
Ah, using cells as the delivery vehicle.
Exactly. These cells, from sources like bone marrow, umbilical cord, or even fat, can differentiate into various cell types and produce a range of growth factors naturally. However, maintaining cell viability and activity after delivery, documenting their effects, and regulating their activity remain significant challenges. We need them to work, but then stop working appropriately.
What about oxygen therapy? It seems like oxygen is fundamental to every aspect of healing. You mentioned it multiple times.
It is. Oxygen is essential for nearly all healing steps: cell energy, collagen synthesis, fighting bacteria through the production of reactive oxygen species by immune cells. We know that chronic wounds inherently have decreased oxygen supply. Supplemental oxygen therapies range from local dressings that release oxygen to systemic approaches like breathing higher concentrations of oxygen or, more powerfully, hyperbaric oxygen therapy, or HBOT.
Tell us more about HBOT. How does that work?
HBOT involves breathing nearly 100% oxygen intermittently while inside a specialized pressurized chamber at pressures greater than 1.4 atmospheres absolute. This dramatically increases the amount of oxygen dissolved in the blood and delivered to tissues.
Okay.
It has 14 currently accepted indications approved by the Undersea and Hyperbaric Medical Society, including various wound-related conditions like severe diabetic ulcers, Wagner grade 3 or higher, necrotizing soft tissue infections, compromised skin grafts, and radiation necrosis.
And does it work for those?
Systemic reviews show beneficial effects on skin graft survival, reduce amputation rates in severe gas gangrene infections, potentially decrease mortality from necrotizing fasciitis, and significantly decreased wound size in non-healing diabetic wounds. While some research drawbacks exist, like lack of large randomized trials for all indications, studies specifically on diabetic foot ulcers consistently show more healing, greater wound reduction, and less major amputation with adjunctive HBOT.
Finally, we need to talk about biofilm. This sounds like a hidden enemy in chronic wounds. What is it exactly?
It's a major factor now recognized as being associated with non-healing chronic wounds, beyond other common risk factors like duration or age. The fundamental difference is that chronic wounds often develop bacterial growth that is inherently resistant to antibiotics and protected from your body's own immune defenses because of how the bacteria live together.
So it's not just bacteria, it's organized bacteria.
Exactly. A biofilm is an aggregate of bacteria tolerant to treatment and the host defense, often multiple species living together, embedded in a self-produced, slimy matrix. Our sources indicate that over 60% of chronic wounds likely have biofilms. These biofilms lead to a persistent, low-grade chronic inflammatory process that directly interferes with normal healing.
How do they form and protect themselves? What's in the slime?
Biofilms form in stages. First, reversible bacterial adhesion to the wound surface, then permanent adhesion and maturation where bacteria communicate through chemical signals called quorum sensing, and finally the secretion of that protective extracellular polymeric substance. EPS.
EPS.
Yeah, the slime. It's like a self-built fortress made of sugars and proteins. It protects the bacteria, allowing for adaptation, virulence, and drug resistance. They can even share genes within the biofilm that confer resistance. It helps them avoid host defenses like immune cell attacks and phagocytosis. And some bacteria within the biofilm can enter quiescent or dormant states, making them even less sensitive to antimicrobials that target dividing cells.
That's astounding. They rebuild faster than you can knock them down. Our sources say they can mature in 2 to 4 days and recover from debridement in just 24 hours. That's a serious challenge.
That rapid recovery is indeed a key challenge. Biofilms stimulate chronic inflammation in the wound, leading to high levels of reactive oxygen species and proteases that damage normal tissue and growth factors. This vicious cycle, with increased wound fluid providing nutrients for the biofilm, creates further resistance to healing. It's a self-perpetuating problem.
So how do you treat them? You can't just use antibiotics.
Standard antibiotics often aren't very effective against mature biofilms. The best method, according to our sources, remains frequent debridement to physically, mechanically remove the biofilm. Weekly debridement is often suggested as being necessary because they reform so quickly.
Right, got to keep knocking it down.
Exactly. Multiple debridement methods, sharp, mechanical, enzymatic, specialized cleansing agents, and topical antimicrobials like silver, iodine, medical-grade honey, or PHMB, are all used in combination to try and disrupt the biofilm and kill the bacteria within. The ideal therapy involves effective removal, antimicrobial eradication, and prevention of recurrence, often requiring multiple repetitions and a multi-pronged approach. It's a persistent battle, and many new antibiofilm agents and devices are under development to tackle this hidden enemy more effectively.
Outro. What an incredible journey we've taken through the world of wound healing. Wow. From the surprising ancient insights of, honey and moist dressings to the intricate biological cascade within our cells and the constant battle against challenges like chronic wounds and that hidden enemy of biofilms.
This deep dive truly shows us how healing is not a simple linear process, is it? It's a dynamic, incredibly coordinated effort. It's really a testament to the body's resilience and the ongoing scientific quest to understand and support it.
As we wrap up this deep dive, consider this. We've explored the intricate symphony of healing, from the smallest cell to systemic factors. But given the body's inherent powerful capacity for repair, what if the ultimate frontier of wound healing isn't just about what we add or do to a wound, but about fully understanding and removing the subtle blocks, maybe inflammation, maybe biofilm, maybe something else that prevent it from doing what it's already perfectly designed to do? What does that imply for future breakthroughs?
Ponder that question and perhaps look differently at your own body's amazing capacity for repair the next time you get a simple cut or scrape.
Thank you for joining us on this deep dive. Until next time, stay curious.